Sickle cell disease is a high-yield topic for the test because we know so much about it. From pathogenesis to treatment and the multiple variants of that therapy, you have to know every detail to get the question right. Sickle cell disease is also a high-yield topic to know about in life because this is a disease that sets in before the kids understand what's happening. And most people live a life of pain in and out of the hospital as they infarct all their organs and die young. So you can do good for these people, both as kids and as adults, by knowing enough about sickle cell disease. So let's start off with the pathogenesis and work our way towards the rest of the disease. First, a normal hemoglobin, alpha 2, beta 2, is hemoglobin A1. The alpha gene is on chromosome 11 and has 4 copies. Alpha is needed for all hemoglobin. If you don't have alpha, you die, hydrops fatalis. But beta only has 2 copies, and it is found on chromosome 16. In the 6th position, if a glutamine gets switched to a valine, you end up with hemoglobin beta S for sickle, which is hemoglobin SS disease. This hemoglobin, under a stressor, can produce sickled cells. Before we move into sickle cell disease, let's talk a little bit more about hemoglobins, just so you have them as a reference. You may remember from embryology that alpha 2, delta 2 is embryonic hemoglobin. And embryonic hemoglobin you can essentially forget about because these kids are not embryos. But the one that is relevant is alpha 2, gamma 2, which is fetal hemoglobin, hemoglobin F. We'll come back to this a bit later. Okay, so under the influence of hypoxia or acidosis, for whatever reason, dehydration, infection, the sickled cells can and will sickle. A normal red blood cell is able to deform, to fit into capillaries. In fact, the size of a red blood cell is too big to fit in a capillary, but is able to deform. In a sickled cell, it becomes rigid and actually looks like a sickle. These cells cannot deform. This inability to deform has 2 consequences. This is an artery turning into capillaries. The first consequence of these sickled cells is that they cannot fit through the capillaries and so get stuck. And distal to that obstruction gets no blood flow. Meanwhile, the other cells that have not sickled continue to deform and flow normally. This is ischemia. The other consequence is that when these cells get stuck up against these capillaries, back pressure occurs, and that causes them to hemolyze, and therefore they have the products of cell breakdown released into their bloodstream. And of course, the non-sickled cells still do what they do. This is hemolysis. Let's explore each one at a time, starting with hemolysis. This represents red blood cell turnover. It's a little explosion symbol. That causes unconjugated bilirubin to be released into the blood, which is brought to the liver, the rate-limiting step of conjugation by 2,3-UDP glucuronidase transferase. Don't remember the name, which is then excreted into the stool. Increased red blood cell turnover is going to increase the amount of unconjugated bilirubin. This has 2 factors. One is going to be that they will always have a little bit of jaundice. In fact, their bilirubin is always elevated. Not that much, but the bilirubin is usually between 1 and 2 as opposed to less than 1 like everybody else. And having all this extra bilirubin around sets them up for pigmented gallstones. Pigmented gallstones means that they may end up having a cholecystectomy. And this hemolysis is occurring all the time. Under stress, more cells sickle and this process accelerates. But at baseline, there's always going to be a little more red blood cell turnover than usual, which is why you always have a little bit elevated bilirubin. That means over time, you're going to develop an anemia. And these patients have a baseline anemia and a baseline elevated bilirubin. And you should obtain that for comparison during an acute crisis. So you want to know what their bili usually is, and you want to know what their baseline hemoglobin is. Someone who has hemoglobin SS disease is likely to have a hemoglobin between 7 and 9. But that anemia causes another problem. An anemia is going to lead to poor oxygen carrying capacity, and that goes to the kidney. And the kidney is going to end up making EPO to try to tell the bone marrow to rev up production of red blood cells. Which means that, as long as their nutrients are there, the bone marrow is going to be trying to keep up with that anemia. And so there'll be a baseline elevation in the reticulocyte count. So you want to know what their baseline reticulocyte count is. And just like any other condition which causes red blood cell turnover to increase, the bone marrow is going to need nutrients in order to maintain constant production. Now, at first glance, you're going to look at those that have short courses, folate and iron. But as we'll see, as these patients become sicker and get transfused, you may actually have to give consideration to deferoxamine or tefacerox. Deferoxamine undo the iron from me because as they get transfused, every 1 unit of packed red blood cells has about enough iron for a year. So transfusions, when they get symptomatic, may result in iron overload. So in the beginning, before they require transfusions, you may be supplementing with iron, but once they start getting transfused, you may be giving them iron chelators. Right, that is hemolysis consequences, cholecystitis and cholecystectomy, transfusions, obtaining baselines so we can compare to an acute crisis, as well as nutritional support and maybe iron chelation. Let's change gears and go to ischemia. In the ischemia category, you have 2 subcategories, acute and chronic. Let's talk about chronic first. What happens when these sickle cells block arterioles and capillaries is you get ischemia, and it affects different organs differently. The spleen, for example, is going to auto-infarct. And for all intents and purposes, patients with hemoglobin SS disease are asplenic. This puts them at risk for infection with encapsulated organisms. And to prevent any infections, you're going to give prophylactic penicillin until age 5. It used to be all children, but this is getting a weaker recommendation, but definitely until 5, probably until adulthood. But definitely these kids are going to need the pneumococcal vaccine. Not every child requires pneumococcal vaccination. Sicklers do. The other organ that can be majorly infected chronically is going to be the bone. With chronic ischemia to the bone, that's a picture for developing osteomyelitis. Now, osteomyelitis is not handled any differently than anyone else with osteomyelitis, but the question always comes up, what is the most common organism? Well, a patient who has osteo, the most common organism is always going to be Staph aureus. You learn for step 1 that if salmonella, then likely sickle cell disease. And that's true. Just because they have sickle cell disease doesn't mean salmonella is most likely. It means it's more likely than in not sickle cell. And if you see salmonella, you should associate that with hemoglobin SS. But if the question asks you what is the most common cause of osteomyelitis, and staff's sitting there, pick staph. If staff's not there, pick salmonella. But infarction of the bone does something else. It can lead to what's called avascular necrosis of the hip. And I say of the hip because that's the thing we care the most about. It can happen to any bone. But the dilemma of what to do for avascular necrosis is really a problem in the leg. The answer is going to be conservative management. Usually for 4 to 6 months, crutches, NSAIDs, get them off the leg and see if it heals. But ultimately, this is like a hip fracture, and so if it does not, you may need to go to surgery. But the initial therapy for avascular necrosis should be conservative management. These are the issues you have to deal with chronically. Let's then talk about the acute issues. The acute issues are going to be either a stroke, that is a focal neurologic deficit or altered mental status, or the acute chest. That is a pulmonary edema in the setting of chest pain or shortness of breath, termed the acute chest. These are both indications for exchange transfusion. You take out the bad blood, you put in new good blood. This is a medical emergency and needs to be done urgently through a central line. Priapism exists in here for guys, but you can try drainage of the penis first. You don't jump straight to exchange transfusion as you would acute chest or stroke. All right, let's come back now to our original eye concept, which is the pathology, and talk about patient presentation. So a person who has sickle cell disease is always going to have a little bit of anemia. They're always going to have a little bit of an elevation in their reticulocyte count, and they're always going to have a little bit of bilirubin being elevated. Most people with hemoglobin SS disease are also going to have chronic pain. And all of the things we've discussed. When you wonder, does this person have sickle cell disease? It is usually found on prenatal screening, but that's never going to be the answer. This is going to give you some reason why the person didn't have prenatal screening. And so what you're going to see on the first diagnostic step is a CBC that shows sickled cells. If you see sickled cells, it's sickle cell disease. It can't be anything else. But what you want to do to confirm it is a hemoglobin electrophoresis. You do this one time, and it will give you the variant of sickle cell disease that they have. We'll finish the lecture with the variants. Then you are going to do either one of two things. You're either going to treat the chronic issues or you're going to treat an acute crisis. If they go into crisis, more cells sickle. There's more pain, there's more issues, there's more of the same stuff that they deal with all the time. And the main issue is going to be acute worsening of joint pain, a vaso-occlusive crisis that is not an indication for exchange transfusion will be treated with intravenous fluids to improve hydration, oxygenation to reduce hypoxemia, and pain control. And this is going to be a major issue. These patients live in constant agony all the time. They're on chronic opiates. The doses will be very high. You will feel uncomfortable giving them as much medication as they need. Remember, there is no upward limit to how much someone can tolerate of IV opiates. If someone's in a crisis, give it to them. You make the original diagnosis with a hemoglobin electrophoresis. This is a one-time issue. For crisis, you're going to look at the sickled cells, the hemoglobin, the reticulocyte, and the bilirubin. If they have an elevated retic count and bilirubin from baseline, their hemoglobin is lower than baseline, and they've got sickled cells on their smear, they are in crisis. Treat them for what they need. If you find an infection, you can treat it. But if they are in an acute crisis in the way of pain, requesting medications, but do not show the objective evidence That is, there's not an elevated bilirubin reticulocyte count, decreased hemoglobin, or sickle cells on smear. You do want to follow up with psychosocial stressors. You have to remember that these patients have been patients since before they can remember. They've been in and out of the hospital and in constant agony their entire life. The hospital can be used as an escape. If they're in a crisis, give them what they need. If they're not in a crisis, still give them what they need, but what they need may not be the pain medications that they're using to escape. They may just need help with something going on at home. Lastly, the way you can prevent vaso-occlusive crises, that is vaso-occlusive prophylaxis, is to give the patient hydroxyurea. Hydroxyurea increases the production of hemoglobin F. Hemoglobin F cannot sickle. If you have more hemoglobin F, by definition, you have less hemoglobin SS, and therefore you have less crises. Everything else stays the same, they just go into crisis left. I'd like to close with a hemoglobin electrophoresis. There's different variants of sickle cell disease, and hemoglobin SS disease is the disease. Hemoglobin SC disease is not the disease. Patients with SC disease are going to have a low hemoglobin, around 11. They don't really go into crises. They can, if they're pushed really hard, climbing Mount Everest with a pulse ox of 50% or a massive infection like a pneumonia, can set them off. Usually they do not. Those patients who only carry one gene, this is autosomal recessive, are called trait. They are carriers only. Their hemoglobin is normal. They do not suffer from pain, but they should be counseled about getting pregnant because they can produce a child that has hemoglobin SS disease. On the other end of the spectrum, hemoglobin S beta thal positive is a more mild form of the disease, while hemoglobin S beta 0 is the worst form. I don't want to go into too much detail here. I just want you to see the letters and recognize that trait and SC don't count. SS is bad. S beta 0 is the worst. We covered basically everything you need to consider. And it will not be surprising for a patient to be on chronic opiates with gut prophylaxis with a stool softener and a motility agent, an iron chelator, as well as hydroxyurea. Lots of medications to be concerned with, and there's a lot of stuff you have to do and a lot of acute and subacute issues you have to be worried about. Everything goes back to the sickled cells. So theoretically, you could do a bone marrow transplant, which have been attempted, but is not the recommended therapy yet. These patients usually die in their 40s or 50s and will have a difficult time getting in and out of the hospital. That is sickle cell disease.